cardiologist in our region. Thank you for being here, Dr. Smith. And Dr. Rosenburg, who some of you may have met, has been here since August as our new VPMA, Vice President of Medical Affairs for the hospital. And tonight we're going to talk about heart health and kind of what it means for men and what it means for women. We're going to go through a few questions, then we'll pause and I'll take a couple questions from the audience. I must admit that light is blinding me, so I may need you to really wave, big so I can see you, but I'll do my best. And then we'll go back to a couple questions. As always with Savvy Women, we do try to make sure that we keep our promise to you and get you out in a timely manner. So our program will go till 6:30, and I'm sure if you have an individual question at the end, we'll be here for a couple minutes at the end, but we'd be glad to chat with you. So I am going to just throw out the first question, and maybe I'll direct initially this to you, Dr. Smith, if that's okay, and that is, what is the number one thing someone can do for their personal heart health, and why?
Well, what are some of the guesses from the audience?
Good genetics.
Exercise, diet,
Red wine.
smoking, red wine,
Diet and
Good genetics.
good genetics. Well, that's really important too, and but you don't get to choose that. So we're going to talk about some of the things that are modifiable. They're called modifiable risk factors for heart disease. So there's two ways that scientists try to figure this out. And one is to study the effect of modifying one of these risk factors and then looking at the outcome. And the other way is to see, well, there's two other ways. One way is to look at who has which risk factors, for example, smoking or not smoking, and then watch over the next 10 or 15 years and see what happens. Another way is to see who had the heart attack and who saw the heart surgeon, and then see what risk factors they've had over the last 10 or 15 years. So those are three different ways of getting at the question. And each of those ways shows different results. So in terms of what a person can do and change to change their risk of developing a heart problem that would require treatment and be expensive and scary would be not smoking. So, and that would be true for all of that's the most modifiable risk factor, and it is the most effective risk factor to modify in my study. This is not my area of expertise. My expertise is clinical cardiology. What do you do when somebody has shortness of breath? But the scientists who study this, that's my impression of what their findings are.
Do you have anything you wanted to add?
Yes, so I think Dr. Smith touched on most of it, but the number one thing you can do to manage your heart health is to manage those risk factors. And as we already mentioned, some of them you can control and some of them you can't control. The ones you can't control, for example, are your family history or getting older. But the ones that you can control are, for example, your blood pressure, your cholesterol levels in your blood, smoking, diabetes, physical activity, your weight, your diet. So those are the most important things. Diabetes is one of the most important risk factors in regards to heart health. High blood pressure has been called the silent killer because sometimes you don't know it. It affects every blood vessel in your body, so it can affect every organ in your body, but it can affect the heart as well and the coronary arteries. But like Dr. Smith said, smoking is the number one thing that you can do. So if you do smoke, because people who smoke have about 6 times greater risk of having a heart attack than people who don't smoke. And also the risk factors multiply. So if you have one, that's probably not so bad, but if you have 1 or 2 or 3, the more you have, the greater the chances that you'll have some sort of a cardiac event. And we'll get into some of those things about controlling them, or how important diabetes is, or high blood pressure, to try to control in regards to lowering your heart risk. I think that come up in some of the other questions.
Great, thank you. So I think people are interested in understanding what are some of the different heart attack system that men may have versus women.
Well, that's a controversial area, and that's an area that people continue to study. The problem with answering that question is the definition of the heart attack. So there exist heart attacks that are from not enough blood going through the coronary arteries. Those are the arteries that feed the heart. And then there are heart attacks where it's more like an attack of heart pain coming from an imbalance between the supply and the demand for some reason. And so the researchers that try to get to the answer to this particular question have always some limitations in the data that they have, in that they don't always take into account that not every time we find little pieces of the heart floating around in the blood, it's coming from an artery blockage. So the word heart attack is a very vague term for a cardiologist or cardiac surgeon. We use a much more specific terminology when we're trying to untangle the symptoms and findings that a person has. So the researchers have defined a type 1 and a type 2 heart attack according to whether it's a problem with the supply-demand imbalance or whether it's really a blood clot forming in the arteries and impeding the artery flow. So, so women tend to have more of the second kind. Women tend to get the artery blockages about 10 years later than men. And when they do get it, there's two phenomena. The newspaper will tell you this, and this is probably the common knowledge that I want to dispel a little bit, because I want for you to hear things that are not what you expect today and make it worth your while. That what you expect me to say is that women basically have more shortness of breath and less typical chest pain and squeezing discomfort anywhere from here to here is kind of suggestive of typical heart pain. And actually the latest, let's see, to answer this, I looked up some work from the University of British Columbia by Karen Humphreys, who was kind of shocked that typical heart pain was present in 78% of women and 85% of men who had heart attacks, essentially. And that's really not that different. My experience has been totally the same, that men have atypical symptoms just as often as women. And there's even, the only person I ever knew that had dizziness as a symptom of a heart attack was a man. And so this is a disease that can happen to men and women. What's different is that the patients themselves and the doctors that hear the patient's complaints sometimes dismiss them more often in women because the disease really is less common in women at the same age. And so that's a little bit of a problem. We know that the rate of, say, cardiac catheterization after presenting with a heart attack, so which is the tube that goes up through the groin or the wrist and squirts x-ray dye, when someone comes in with typical heart pain and their blood tests show pieces of the heart floating around in their blood, which is one of the essential tests that we do to evaluate that problem, women have a significantly lower rate of being sent to the cath lab for getting those procedures. The problem is that there's maybe some reasons for that, because sometimes the women are 10 years older, and sometimes they say, I'm not really that interested in knowing, whether I need open heart surgery or not, because I'm at a stage in my life where I don't really want that. The other reason is because sometimes they're more susceptible to heart attacks without coronary artery blockages. They can have a syndrome called Takotsubo. Sometimes we see 2 of those at Sierra Nevada in a single day. And what happens is the heart, for some physiological or emotional shock, like lots of inhalers for an asthma attack, or being in distress from pneumonia, or having an emotional shock like witnessing a terrible accident, the tip of the heart may become paralyzed, and the heart may become weak. And this can happen, with typical heart pressure symptoms and with of heart problems in the blood, and it can be associated with no artery blockages. So I would send a patient that I'm suspecting that problem less often for the angiogram. So there may be explanations for why women are less thoroughly investigated, you know, when you just compare it to rates of catheterization. But I think it's mostly not true. I'll give it a mostly not true that women don't get heart pain.
And I'm just curious, what are some of the other kinds of cardiac issues you see besides what we think of as heart attack? You know, what comes through your office?
Well, what we see in the hospital and the office is women. So, say a woman has symptoms of a heart attack, which would be chest pressure, shortness of breath, discomfort anywhere from the upper abdomen to the jaw, and they may have some imbalance between supply and demand with their heart, either from low supply of blood, say severe low blood count from bleeding from the intestines, or a particularly high demand, say a new rhythm problem, say for like atrial fibrillation, where the heart's racing at home at 180 beats a minute for 5 hours before some of the women that we see are very tough. And they will put up with a lot of discomfort and a lot of heart problems before they come in. And so one of the reasons that we like to come talk to the public is we like to make sure that as many people as possible know that some of these things, it's really not their own job to figure it out at home, you know, what's going on. That's the ER doctor's role, etc. So sometimes there can be a typical heart pain and not your typical heart blockages. And sometimes some other problem like anemia or atrial fibrillation will unveil. You've heard of triple vessel bypass surgery? Who's here has heard that word? Triple vessel bypass surgery. So if you could have artery blockages, and so it's possible, just knowing that word, you realize it's possible to have lots of blockages, at least 2, right, without realizing it in your heart. Because why would the person need to go have 3 vessels fixed if the first vessel and second vessel, when they blocked off, they didn't cause any symptoms at all? So sometimes it's some other thing that just unveils the disease. And so those typically are kind of in the gray area, not really heart attacks and not really not heart attacks.
Great, thank you. Did you have anything you wanted to add to that?
Yes, I think that as we know, there are differences between men and women. The biggest one is that women have higher endogenous estrogen. And so in the childbearing ages, that estrogen could be a protective effect. Estrogen has an effect on blood vessels where it can dilate them and keep them open. So generally, women in the childbearing ages have a very low chance of having a heart attack. The ones that do ordinarily smoke, it's associated with smoking, or they have lower levels of estrogen levels. So the other difference is that men have larger arteries than women do. Women have smaller arteries. So the classic symptoms of a heart attack, which everybody most likely knows, is the crushing, mid-sternal chest pressure, and sweating. So those are the ones. But sometimes the symptoms can be different, or you can not have symptoms at all when you have a heart attack. Oftentimes, people who have diabetes they may not have symptoms when they have a heart attack because diabetes also affects the nerve endings. So men who have heart attack usually have a complete blockage of the artery that we call thrombosis. So within the artery itself, you get deposition of cells, usually from an injury, and those build up. And then when that plaque has an injury to it, then you get cells called platelets that are the first cells that cause blood clotting, and those can form a blood clot, and then the vessel closes off completely. And those are the classic heart attacks, and those are more common in men. Women oftentimes have plaques that are within the wall themselves, and they get narrowing, and they don't as frequently get the complete blockages, but they can get them later in life. So it depends on what's going on inside the artery. Will depend upon what kind of symptoms that you're having.
Well, I'll start with you, Dr. Rosenburg, on the next question. One of the things that I get asked a lot, and I think people wonder about is, well, we don't do heart surgeries up here. So the first question is, why don't we do heart surgeries? And so maybe you could talk a little bit about, the relationship with the Mercy Heart Institute and, yourself as a surgeon, why, it's a great thing that we have our heart patients go down to Mercy Heart Institute.
Thank you. Well, mostly what we do, and Dr. Smith really, since he really takes care of patients in the hospital, but mostly what we do at Sierra Nevada are diagnostic tests. And we have several different ways of doing diagnostic tests. So if someone's having a major heart attack, where if you take an electrocardiogram and you look at it and it shows heart injury, usually there's what we call elevation of some of the, we call ST segment elevation. Those people usually need to have intervention right away. So there have been times where we can give, and time is muscle, both for strokes and for heart attack. So the sooner you get treatment, if you have a blockage in your artery, the less amount of damage there will be to the heart muscle. And it also depends on where the blockage occurs in the artery. If they occur closer to where the blood vessel comes off of the aorta, then more of your heart muscle is going to be at risk when you're having the heart attack. So those are the ones that have a chance of being fatal or causing a fatal arrhythmia like ventricular fibrillation, some abnormal heart rhythm that cannot sustain life, as opposed to one that's more further out in the blood vessel. You can still have a heart attack, but it won't affect as much territory, and so your disability from having the heart attack won't be as great. So we can give thrombolytic medicines there, things that can dissolve these blood clots while you're then getting to a place where they can do either a catheter-based intervention, where a cardiologist could do a stent or something to open up the artery, or in some instances where you might need to have surgery to bypass the area of the blockage by using some artificial conduit, either an artery or a vein that's sewed onto the aorta and then sewed on distal beyond that area of blockage to bring blood flow to the heart. And then there's other heart attacks you can have that aren't quite as profound, where you're not having as much injury to the muscle of the heart, so you have a little more time to diagnose those and treat those. And timing of surgery or intervention is also important. So they say, for example, if you're having a heart attack, if you came to an emergency room, you're supposed to go from the emergency room to the cardiac catheterization laboratory within 90 minutes. Well, we don't really have that benefit here, and oftentimes you're not diagnosed. So you should be taken to the place where you can have the most appropriate intervention done first. If you are taken, if you're in Nevada City or Grass Valley, you're most likely to be taken to our emergency room, where the doctors are very skilled at making the diagnosis. And then we have cardiologists and cardiac surgeons who are available by telephone 24/7, 365 to help us diagnose and accept care of a patient, in which case we can either send people by ambulance or by helicopter to Mercy General or Mercy San Juan, where they have catheterization laboratories or bypass surgery. And they have full service of procedures, cardiac procedures at Mercy General. They have coronary artery vascularization and a few other things at Mercy San Juan. So it's not quite as full service. So those hospitals are very important to us, and we like to try to get our patients to those facilities. For some reason, if we can't, then our emergency room doctors do send people to the nearest place that can take care of them. Some of our people do end up going to other institutions.
And one of the things we're working on through a grant that we've gotten is some work with our hospital and the Greater Sacramento to eventually be able to have telehealth for cardiology in our region. As I said, you do things by contact and phone, but we actually have robots and are working on one of those for cardiology. And I always explain to people, because they're like, you have this big senior population here, and I'm like, but you got a big senior population, but you don't necessarily have enough people on an ongoing basis that need surgery every day. And if you're going to have surgery for something, you want to go where someone's doing it all the time, not just on occasion. And Mercy Heart Institute is one of the very best in the country. And so the hospital has really perfected that seamless back and forth within that Mercy Dignity Health system to make sure that you are getting very fast and expedient care in that area. Dr. Smith, I'd like to have you talk a little bit about after someone has had their cardiac incident and they come back to this community, what are things that we offer here, for them at that point, and how do they then get connected in and work with a cardiologist here?
Well, one of the unexpected benefits from ending up at an institution like Mercy General, Mercy San Juan, for our community is that almost all the doctors and the hospital are electronically connected to those two hospitals. So we can go in, if you come to any doctor's office in this community, they can take a look in the computer and read all the notes of all the days at the hospital. And that's an advantage if you end up at UC or UC Davis or whatever. There's always a few days of paperwork shuffle or faxes or whatever to try to get the whole story of what happened. And so Mercy's built a nice system. It's pretty seamless. Someone comes back, they're asked to follow up in my office or one of the other cardiologists up here, and we just log in, we take a look at what happened, and we make sure that the instructions were all understood, that the medications are agreeing with the person. We make sure that the plan is carried forward, and sometimes maybe they only fixed one of the two arteries that needed to be opened. And sometimes the person's discharged from the hospital and doesn't even realize it because so much was happening. And we have to say, oh no, they didn't want to give you so much x-ray diet all at once. We do need to schedule another visit down there for another angiogram. So things like that are really, really important to get seamless follow-up and make sure all the records were received and understood. The next step is to make sure that all the new problems that come after open heart surgery, whether it's numbness here or shortness of breath or not enough diuretics or something like that, that's all being addressed. And we have another suite of diagnostics we can do at the hospital, x-rays and ultrasounds and that kind of thing, to make sure that all the basic cardiac care is being taken care of. Once the person's stable enough and in a good enough shape, we'll move on to what's called cardiac rehab, where we send someone for a few days a week, depending on their schedule, for up to 6 weeks after one of these events, because many people are debilitated. They've maybe not been diagnosed for a while, and they've cut down all their activities and become much weaker than usual, or much weaker than their potential really is. And they may not even realize that they've been choosing the elevator instead of the stairs for the last 5 years. And it's because of their heart, not because of their legs. And so we need to kind of promote exercise and get some of our patients who are in that state back to usually a better level of health than they were in before this ever happened. So almost everyone who completes a cardiac rehab program in Sierra Nevada says they're in better health than before their heart attack ever happened. And so that's really, really good news. So at the same time, the doctors are seeing you less and less frequently, and some of the work is the doctor's job to get all the medications right, and some of it, increasingly as all the doctor's job is done, some of it becomes the patient's job to do. And then we have a lot of people who continue to do cardiac rehab for long term. Some of them have anxiety problem, and without being monitored, I am not exercising, not with a heart problem. And some people just find that unless they have the collegiality that you find there at the cardiac rehab, they just tend to not exercise. And then some people just really just feel so much better since they've been participating in that, and they don't transition to silver sneakers based, gym-based exercise. And some people continue to have medical problems that require monitoring, and that's a little unusual. So our patients will then do their part with counseling and exercise, and believe it or not, it's pretty modest exercise, and they feel way better than they did before. With the combination of all the surgeries, getting all the arteries open, all the valves fixed that need to be fixed, getting the rhythm stabilized, and getting all the right blood pressure medications, changing the meds so that they don't have side effects. And then they do more and more exercise, and over about 6 weeks, even after the most invasive open heart surgery, typically they're in better health than they've been in years.
I would just add that a lot of people that haven't been in other places and had, perhaps cardiac issues might think cardiac rehab departments are really common in hospitals, but we're actually pretty unique that we have not only a cardiac rehab program, but a pretty incredible, cardiac rehab program that within the entire Dignity Health region is seen as to be the shining star. And we really have a fabulous team, Katie and her group that work there. They're going through a move. They're moving to a little bigger and nicer space, so they're going to be really happy. Great views out the window. And to put in perspective, through a cardiac program at the hospital, we handle about 30,000 patient visits a year. It is a very, very active program that we have there. I want to take just a brief moment and just see, are there any specific questions? Tom?
I have a question. When you say you have your blood vessels blocked and you're having problems, and then pretty soon pieces of your heart go through your artery, how does that happen?
Pieces of your heart go through your artery, that's the question.
Right, so one of the ways that the scientists have invented for us to rapidly figure out, this has to do with mostly the ER. So to sort out people that are having heart pain, and the reason why you can feel confident, coming to even a little hospital that doesn't do open heart surgery, is that the point of going to the ER is rapidly figuring out where you need to be, because sitting in the emergency room for 8 extra hours at Mercy General, where they do open heart surgery, doesn't help. It helps to get the diagnosis right at the very first 1 or 2 hours when you're there, so that then you can immediately be in the cath lab at Mercy General hour 3. It doesn't really matter which ER you go to as long as the diagnosis is made rapidly. So what are the techniques to figure that out? Well, we have tried and true EKG. We have the symptoms, which are kind of 50-50. And we have a very amazing blood test called the troponin. And we have a really rapid turnaround on that. It's very specific, which means not many organs create it, only the heart. And very sensitive, which means very little damage has to be done to the heart for us to be able to detect it. And what we're actually testing for is proteins, which are the actual building blocks of the heart tissue, that are made in the heart muscle, and they actually have a function, but of course they're broken apart, that are not made anywhere else in the body. So we can detect very tiny levels of those in the blood. So if the heart muscle is under strain for any reason, it's not getting enough blood, or the blood pressure is 250 millimeters of mercury, and so each heartbeat is under a lot of strain, whatever it is, we can test the troponin in the blood, and that will tell you that the problem is much more severe. And that troponin is little tiny microscopic pieces of proteins of the heart that have, that have come from cells that have been damaged. The cell wall, or that's a plant, I'm sorry, the cell membrane has broken apart and released these proteins into the body, and they float around in the veins. And so they're found in a standard phlebotomy blood test, and we can, our ER doctors can rapidly figure out, zoom in on symptoms, zoom in on the EKG, zoom in on the troponin, and then the whole medical situation, and rapidly come up with a likely group of diagnosis it can be. And that's when they usually call, the cardiologist on call, and then we come up with a provisional diagnosis and plan. When it looks like it might be the real thing kind of heart attack, then we get on the phone with the cath lab downtown and say, make a room for our VIP patient. And they basically just say yes. This is the best system I've ever worked in terms of transferring patients for advanced care.
So I'm just curious. we'll just, myth or reality? An aspirin a day. We all have heard it, right? If you have heart situation, is that a myth or a reality?
Well, first of all, if you are having a heart attack or you think you're having a heart attack, don't drive yourself to the hospital. Call 911. Take a 325 milligram aspirin, uncoated, and chew it, because it has an antiplatelet effect. We talked about platelets. Those are the cells, the first ones that go help to form a blood clot. Call a friend or a relative to come over and be with you. Unlock the door and go rest, and then have them take you to the heart attack. You should not start aspirin therapy unless a doctor tells you to. There are some reasons not to take it. If you have a bleeding disorder, if you have an ulcer disease, or if you have an allergy to aspirin. But generally, it's given to people who have certain more than one risk factor for heart disease. And so if you have diabetes and one other risk factor, for example, if you're a man and you're 50 years old, then you would be a candidate for taking aspirin. Or if you're a woman 60 years old of age and you have two risk factors, then you would take aspirin. If you've had prior cardiac surgery or you've had prior cardiac stents, something like that, then you would need to be on aspirin therapy.
Did you add anything to that?
Yeah, there's a new publication in Epidemiology, December 2017. Dr. Huang at the NIH reanalyzed all the data on this and found that in people, again, without risk factors, that there are the people at the lowest risk for heart disease, for having established heart disease, actually cause harm to be on aspirin every day. And it's those people who are at higher risk and have had established heart disease that aspirin is beneficial. So she called it a U-shaped risk profile. So it's so basically what that means is that, and it stands to reason, if you have no atherosclerosis, if the arteries are smooth as a baby's bottom, as the interventional cardiologist will say after looking at some people's angiograms, if they are super smooth, why taking aspirin will only cause bleeding. But if you have artery disease that you don't know about, so that's where the risk factors come from, is because most people with artery disease don't know they have it, and they don't realize how much they have. And so we can start to detect that. You know, one of the advanced technologies we have here in Sierra Nevada is a wellness scan, and it can find this artery blockage for a kind of a reasonable price. It's not covered by the insurance company, but we can do that for you, and if we can find artery coating of calcium on the inside of the arteries 10 years before it causes a problem. And so it's probably, if you designed a study to test the hypothesis that aspirin's beneficial, it would probably be only in those people with artery blockages, with artery calcification. The more atherosclerosis the person has, the more the benefits of aspirin daily are going to outweigh its bleeding risks.
So we're almost to the end of our time. We're going to take time for one or two quick questions, and then we'll be glad to stick around.
How successful has the hospital's heart wellness test?
You mean that CT scan?
Yes, I mean, you go in and you pay them $185, and they will. In fact, we saw it at the Platte County Fair several years back, and was started. I'm assuming that it's still available. I had my sons take it, and it's called the heart wellness test.
Were your sons surprised by their results?
They were good.
Yeah.
The heart wellness scan is the question.
So the heart wellness scan, I think Sierra Nevada offers that for about $185, and to rent a multi-million-dollar machine for an hour is probably, they're not making a whole lot of money on that. We tried to keep the price to something that the general population would be able to afford themselves. Is a political issue, because there's no way you can prove that a diagnostic test will improve your risk of a heart attack, because that's not the nature of a diagnostic test. So, so it's not paid for by insurance because they continue to say, well, show us proof that doing this heart wellness scan will lengthen this person's life. Well, it's impossible to really prove that. It depends on what you do about the diagnostic scan that will decide whether the person will live longer. Now, if a person got a diagnostic scan and realized that they have more atherosclerosis than they expected, they would be able to take aspirin. They would be able to be more motivated to take cholesterol medications. And they would maybe be more attentive to heart pain if they developed pain that they weren't sure whether it was coming from their esophagus or their heart. And more willing to subject themselves to stress tests, and more willing to be on blood pressure medications. In those patients, it would make a huge difference. You know, there's also a lot of people with high cholesterol levels who are just absolutely sure that they don't have atherosclerosis and they don't want to take cholesterol medications. And a heart wellness scan that shows not even a tiny bit of calcium in the arteries is very good information for a person like that. It may provide very good evidence to an individual that maybe a group of people with high cholesterol, you can say 70% of them would benefit from cholesterol medicines. But that doesn't mean that that one individual, it makes it more individualized. So often the guidelines, basically, the guidelines for who should be on cholesterol medicines, for example, and this is what that scan is really for.
So last question, someone have a last question? Yes.
Well, my son had that heart wellness test and does have a plaque in his artery. He's on all these medications you're talking about, but why is that's the prevention of a heart attack? Not putting a stent in, you don't do that in this case?
So in the case of somebody who has, and many of us in the audience and me in the future, will have these arteries will start to get atherosclerosis. You can find it in unfortunate veterans even in their 20s, you know, if you do autopsy studies. So most of those blockages, that disease won't ever cause a problem. But this artery disease can be very focal. And if one part of the artery constricts, it can cause severe damage to the blood supply, to the tissue that it's supposed to supply. So it's a little bit, the scan is more like a measurement of the amount of artery disease, not whether any particular artery is blocked off in one focal place. It doesn't really do that very well. That we do stress tests routinely for our community, and we do that especially when someone has vague symptoms, you know, or very suggestive symptoms to rapidly make the diagnosis. But this scan, it will mean you can basically guess what the amount of atherosclerosis is from the risk factors. But it will show people at the edges that have more or less artery disease than you would expect. There are some people with high blood pressure and diabetes who smoke who don't have artery disease. And there are some people who aren't diabetic, who have normal blood pressures and don't smoke, and their cholesterol level is not particularly high, who are in the ER having a heart attack. And as a matter of fact, when I was at UCLA, they had published an article recently that they were working on in the emergency room that showed that about 40% of the people having heart attacks in the emergency room wouldn't have been put on cholesterol medicines the day before their heart attack if they had seen their primary care doctor who followed the guidelines. So that tells you the guidelines are basically they work with averages of large numbers of people. We can be very sure if we have the larger number of people, 1,000 people with a certain cholesterol level, you can say almost with perfect precision what percentage of those people are going to have a heart attack by age 70. Any individual, it's a little more iffy. And so the idea with this wellness scan is in those people who are intermediate, between taking cholesterol medicines and not, or taking aspirin and not, or if we have, even sometimes we do stress tests and we're not sure if they have artery disease or not, we can then measure the amount of actual atherosclerosis. And the reason this is available now is because technology has advanced, computing power has advanced. So because the heart's moving around, you need a more advanced computer to try to correct for that.
Unfortunately, we're at the end of our time, but I'm sure the doctors will be glad to stick around if you have questions and want to come up and talk to them. I will say we do tours through our cardiac department. If you have never been on a tour, it is a great thing to go through, and we also do education programs at the hospital. I also didn't mention earlier, and I should say there are cardiac support groups for people that is of interest. So really appreciate you all coming here. Dr. Rosenburg, thank you so very much for being here. Dr. Smith, thank you for being here. Thank you all for being here. I have to say, it's just so wonderful to see so many wise guys here, so we may have to try this again sometime. Thanks so much, and as I said, we'll stick around for a few minutes in case you have questions. Have a great evening.